Hi, everyone. Welcome back. My name is Michael Irwin. I'm a professor of anesthesiology at the University of Hong Kong. I'm Irishman, educated in Scotland, and I've worked in Hong Kong for just over 30 years now. So I talked in the last lecture about audit and the importance of audit in shaping our current specialty, and now I'd like to speculate a little bit about how our practice may change in the near future. I emphasize the near future because I think, it's not the realms of science fiction. It's anybody's guess what things are going to be like in, 50, 100 years from now. But this is really more about how things are starting to change currently and where we might be, 10, 20 years down the line. Now, my disclosures are really related to editorial boards. I have no pharmaceutical or equipment company associations currently, certainly not within the last few years. In fact, I haven't been anywhere for the last few years, just like I'm sure the same as all of you. Right, now this gentleman, Richard Buckminster Fuller, a very long-lived and intelligent man who came up with this concept of the knowledge doubling curve. He noticed that until 1900, the body of human knowledge seemed to double about once every 100 years. So, pretty slow. But then by the end of the Second World War, we're now on to the Third World War, well, hopefully not actually, but anyway, he then felt that knowledge was doubling every 25 years. And so is 4 times more quickly. And unfortunately, as you might expect, progress does tend to increase in times of war and adversity because that will increase your competitive edge over your adversary. And on average, it's now taking around a year for knowledge to double. And in some areas of technology, it may even be weeks, days, and it's even being speculated that some things, even hours. So very, very rapidly traveling. If life's a journey, then in this year or so, we're traveling by rocket. Now, this is knowledge and experience is reflected in our specialty very well in terms of anesthesia mortality. I've taken anesthesia mortality from Australia, but mainly because Australia, they keep very good records of mortality, and the most recent data that I could find was from 2013, Neville Gibbs, published in the journal Anaesthesia and Intensive Care. And you can see that between the 1980s and that current time, probably we're around the same now, mortality has decreased from about 1 in 76,000 right down to probably less than 1 in 360 or 1 in 500,000. So that's really making a difference for our patients. And that's despite the fact that we're dealing with older and frailer patients and probably bigger and bigger surgeries in these particular patients. Now, anesthesia is obviously pretty safe, as you can see from that statistic, but unfortunately, surgery can still be very dangerous. So that's where you see a lot of the morbidity and mortality is actually associated with surgery, although anesthesia may be a contributing factor in some of these. In the year 2000, the 30-day mortality risk in the UK was as high as 1 death in 34 emergency surgeries, much lower, obviously, in elective surgery. So surgery, not anesthesia, is still increasing risk for patients. And we, as a specialty, may well have a role in helping to combat that. And I think that's something, this collaboration between surgery and anesthesia and some other medical specialists in driving this better perioperative care, what we're referring to now as perioperative medicine, is going to be very, very important. So perioperative knowledge comprises various different factors. Of course, we have our clinical experience. Clinical experience is important, but clinical experience, perhaps that's something that can be driven by artificial intelligence, computers, and so on. We have technological innovation. We have research and audit, which I think is obviously very important. It's what I addressed in the last lecture, the circle of care and reflection, and then increasing in improving patient care. This general concept of wisdom, why is somebody a very clever consultant or professor or whatever, all this wisdom? Is our work an art or craft? This is a matter of some debate. Some people like to say that there's a certain art associated with what we do in anesthesia. Other more pragmatic people would dispute that and say there's no place for art in a scientific specialty. Maybe that's something that we could discuss later. So application of new technology is where we undertake a task which would be otherwise impossible without this new technology. Or it may be something which allows us to perform a task which we can already do much better than we can with present technologies. So you see this in all sorts of spheres of life, from communications, submarine cables to satellites, mobile phones, 2G, 3G, 4G, 5G, and so on. And we see the same thing in medicine, the ability to perform tasks better. For example, the early days of trying to do tracheal intubation, and then better laryngoscopes, and then video laryngoscopes, things like fiber optic technology has come in, and then that's allowed us to do other things much better, and so on and so forth. I think you can see this very clearly in all sorts of different spheres of medical care, not just anesthesia. When we talk about innovation, actually, one of the mistakes people make, I think, as a concept, is to think that to associate innovation only with technology, but it doesn't actually just mean technology. As an example, the initiative of the World Health Organization in the Safe Surgery Saves Lives, the surgical safety checklist, is a very, very simple innovation. Just simply introduce a checklist which encourages communication between team members, encourages us to discuss the issues and problems that each of us may face with the patient, the patient issues, the surgical site, antibiotic administration, all these various things. And if you look at the data, this is data from New England Journal, which looked at the introduction of the surgical safety checklist in a number of cities in the United States, 8 hospitals in 8 different cities, found that the rate of death was 1.5% before the checklist was introduced, and it basically halved afterwards. And it was the same with inpatient complications. Now, if you had actually invented a drug which you could administer to a patient before surgery, which reduced the rate of death from 1.5 to 0.8%, it would be an absolute blockbuster. You could name your price for it. And yet, this is just a simple checklist innovation. So don't always think of it as something fancy, technological. And to go back to anaesthetist being the perioperative physician, because I think this really is the future of our specialty. Anesthesia as a specialty, or as you guys call it, anesthesiology, has set a very high standard for intraoperative care, a very, very high standard. This is, the work of our predecessors and ongoing work in this field. It now encompasses the whole surgical journey. So I think initially the focus was very much getting patients through the actual surgical procedure. So anesthesia is really thought of, rendering that patient unconscious or the regional anesthetic from the surgery, and then getting them into the, post-op recovery ward and back to the normal ward. But that is now extended to the whole perioperative care process. And, most of us are very much involved in seeing patients early before surgery, identifying comorbidities, improving those, and getting them through the whole process and, right through postoperative care. Anaesthetists or anesthesiologists were the pioneers of intensive care, for example, and that's really just an extension of that surgical journey. The important thing is that, I think we are taking the lead in developing this, but it's very important that we do, because there are many other specialties waiting in the wings that would be very happy to get involved in this. I think that the importance of this field is being very much recognized by many of our colleagues in different disciplines. So we get things like enhanced recovery after surgery. I think, again, I'm sure you're all very familiar with this. Evidence-based multidisciplinary care, trying to reduce length of stay, complications, reducing variability. This is important. Consistent quality of care. It may be expensive sometimes to initiate some of these new innovations and so on, but ultimately they do seem to reduce cost as well as improving quality of care. And that obviously improves value, because value is quality divided by cost. And there are a whole different facets of this. I think, again, this slide is really just to emphasize that this whole thing is not just how we manage the patients during surgery. It's not a case of a recipe of giving certain anesthetic drugs or whatever during the operation, give this drug and don't give that drug. It's actually a concept of the whole perioperative care process, from the point that the patient is seen by a surgeon and the surgeon decides that patient needs surgery until they walk out of the hospital afterwards. So we have things like artificial intelligence, data analysis, and things like telemedicine. These are important as well, because they permit rapid data analysis. Rapid data analysis allows better preoperative assessment, allows us to do things like stratify risk, allows us to identify patients, particularly in emergencies, who are deteriorating rapidly and going to either need surgery or need resuscitation. There are also things like closed loop feedback systems, which I'll come back to, because there are varying degrees of success with these. Certain areas like blood pressure or glucose monitoring, neuromuscular blocking, is relatively easy to do. It works pretty well. Others, such as anesthesia, nociception, not so good. Artificial intelligence remote care has, paradoxically been increased by this current COVID pandemic, because we're having to do much more remote care. So it's very well described already in things like radiology, where radiologists can interpret X-rays and MRI scans and so on from the comfort of their living room or whatever. But also now things like ultrasound-guided regional anesthesia, echocardiography. There are remotely monitored virtual intensive care units. There's the so-called hospital at home, where patients can be discharged to their own home and still remotely monitored. Obviously not at high level, but well enough to be able to identify deterioration or the need for readmission. So remotely delivering intraoperative management is even a theoretical possibility, certainly not quite there at the moment, but you can see that there is a potential for that, and perhaps that's something that we could see in the near future. We should be seeing a more paperless working environment for the benefit of the overall environment. We'll be seeing less and less cables stretched out all over the floor and so on, because now we have more and more monitors are being developed with cables being replaced by short-range signals and so on. There are new innovations such as the operating table. Well, you see the simple thing, but still pretty useful, that the operating table can be remotely operated by the surgeons rather than asking us or the nurses to move the table, and they can adjust the light themselves, often just with eye tracking and this type of thing. So this kind of technology already exists and starting to be used. In our own hospital, for example, we have moved to electronic record keeping, not just for the intraoperative care. Our staff are all issued with iPads or Android pads that can be used for preoperative assessment and so on in the clinics and the wards. And we also have included things like PPOSM, risk management scoring and so on built into that, so they will link up with the patient's physiological data, biochemical, hematological analysis and so on, and will then calculate for you things like patient's ASA status, PPOSM, so you kind of rough idea of what patients' risk of mortality and morbidity is. And these are issues that can be discussed with the patient and with the relatives prior to surgery, and can also help us to decide the level of care they're going to need both intraoperatively and postoperatively. So I think these are innovations which we're seeing already, which are already making quite a difference to how we manage patients. So the future of our specialty is perioperative physician and this an early recovery after surgery. Now, what about things like physician assistants? Now, I know this is not so contentious in the United States because it's actually quite well developed in the United States for a fairly long time. I know you have what you call nurse anesthetists, but this is not something that is so familiar where I work or in Europe. But I think it's becoming more likely now, I think, because of workforce shortages, the need for the time needed for training, reduction in work hours, which actually reduces the time available for training and so on. It's well known that there's an inverse relationship between surgeons' outcomes and their caseload. It's not been described in detail for anesthetists, but it seems logical that the more you do, the better you're going to be at what you're doing. There is some evidence of that, even within our specialty. In major surgical procedures, for example, anesthetists who delivered higher case volumes had lower risks of combined major morbidity and patient readmission over a period of 90 days. So this is very clear medical legal consequences in planning, service provision, things like, would it be more appropriate to provide more specialist anesthetists for major cases? Yes, I think it probably is. Perhaps this whole issue of physician assistants, nurse anesthetists is something that could be discussed in detail during the discussion period. So applying new technology, undertaking new tasks, performing tasks better. What about things like this, for example? If you look at this is a cartoon which was actually taken, see from the date, this is Windows 95. So this was actually, well, now maybe nearly 30 years ago that this cartoon was published. And it's kind of funny, but at the time, this was a big concern, when the thought of robots performing surgery, what was going to happen? Would they go crazy? Would this sort of happen, et cetera, et cetera? It is sort of seen as a little bit of science fiction, and yet it's something that's an everyday occurrence now. The robots are still being controlled mostly by humans, but that could well change. And I think robotics are generally likely to supersede a lot of technical skills, not just for surgeons, but for us as well. You see here, this is an intubation robot, which I think was developed at McGill. Looks pretty cumbersome looking thing, but obviously these things in the early days are going to be like that and should improve with time. The system below, the name escapes me for actually, the Magellan system. This is already available now for ultrasound guided regional anesthesia. So that's a robotic assisted techniques for that as well. So you can see that this is a new area which is coming into our work. Portable point of care ultrasound. I mean, basically, who needs a stethoscope nowadays? When you've got your pocket ultrasound. I have one of these. They are getting cheaper. They're not obviously not cheap, but they're getting cheaper and cheaper, and will continue to get cheaper, I think, so that they will become more and more ubiquitous. And so, you can do point of care ultrasound at the bedside in the clinic. You can use it for intravenous access. You can use it for doing blocks. You can use it for arterial lines, central lines, all sorts of things. You can use it to see whether your patient is properly fasted or not. New and new things coming out all the time. There's now a robot which has been designed for autonomous vascular access, and apparently is actually very good at it. And the data published in this particular journal, which may have a bit of bias because these authors have developed this technology, claim that their machine is even better than the human hand at vascular access. And it's a technique which is using both near-infrared spectroscopy and duplex ultrasound imaging together to find the suitable vessel that can distinguish between arteries and veins, and then to cannulate it for blood sampling or to put in needles and catheter insertion. So again, you see very cumbersome looking equipment currently, but that's always the way. When we look back at the old anesthetic machines and so on, at some point, it's likely that these things will become available for clinical use. Now, I want to briefly talk about intravenous anesthesia. This is one of my big things of big interest. I think TIVA is a very important standard anesthetic technique, which all anesthesiologists should be competent in. And the reason I mention it is because I think in the future, it's going to become more important in anesthesia care. It's already starting to increase quite a lot for various reasons. There are many advantages of propofol-based intravenous anesthesia. I've listed them here. Don't want to go through them all in detail. I think most of you would know these. But these, and certainly the environmental issues are very, very much coming to the forefront. I actually had written a textbook about intravenous anesthesia called sort of educational book called Taking on TIVA. And then I found in the last year or so, I've been getting more and more invitations to run workshops and so on related to TIVA. And actually, one of the main reasons is this environmental concerns. It's not the other things I mentioned there are important as well. I think the two big things are the environmental issues, climate change, and cancer. I'll come to the cancer a little bit later. Anesthetic gases allow the atmosphere to store more energy from the sun than carbon dioxide. So, for example, 1 kilogram of desflurane is equivalent to about 2.5 tons of carbon dioxide. And all volatile anesthetics have potential to damage the Earth's ozone layer. But desflurane is far and away the worst. And in fact, to the point that many hospitals have actually banned the use of desflurane. Many in the UK, I think, have banned desflurane. They've taken it away. It's not an option. I was giving a talk about this at the World Congress a few months ago. And so I used this illustration because the World Congress was in Prague. I wasn't in Prague. I was in my bedroom, as I have been for the last 2 years for every lecture I've given, just like today. And I use this as an illustration. If you use desflurane for 2 hours, 1 Mach, a 2-liter fresh gas flow, that is equivalent to driving a medium-sized car from Paris to Prague in terms of the global warming potential. So that kind of very stark illustration. So the second thing that's caused a big increase in the interest in propofol-based anesthesia is cancer surgery. Cancer surgery is well known to be a potent trigger for metastasis and cancer recurrence, and there are many influencing factors. You could almost call it like a perfect storm of things which occur during surgery: the surgical stress, immunosuppression, inflammation, the handling of the tumor, dissemination of tumor cells. We've been doing some research on this, and we found that, for example, during hepatectomy, liver surgery, even with very meticulous surgical care, we can measure quite high volumes of circulating tumor cells getting into the circulation, and we can pick them up in venous and arterial blood and so on. So this is an issue. And the interesting thing is that propofol appears to have some anti-tumour properties. It enhances cytotoxic T lymphocyte activity, inhibits cyclooxygenase, which is a trigger of inflammation, and inhibits hypoxia-inducible factor. That seems to be actually one of the main reasons for its potential anti-tumour effects, actually, when you look at it in cell cultures and so on. But if we go to the clinical setting, there are a number of studies which are ongoing looking at this prospectively, because there's quite a lot of retrospective data which is very supportive of the use of propofol in cancer surgery. This is, I'm sure you probably know this study, it's quite well known. It's by Tim Wigmore and colleagues done at the Royal Marsden in London, which is a big cancer hospital. They only do cancer surgery. They also do a lot of TIVA. They did a retrospective analysis of 7,000 patients, half of whom received inhalational anesthesia, half received propofol-based TIVA, and they found that mortality was 50% higher with the volatile than with IV anesthesia, and that's with propensity matching, etc. Of course, we don't know whether this is related to the anesthesia or some other factor, which is why it's very important to do prospective randomized control trials. Limitations of TIVA, I think one is that you in the United States still, as far as I know, don't have target-controlled infusions, and target-controlled infusions are what make intravenous anesthesia very simple. Having said that, it hasn't been entirely simple, partly because there were too many choices of PK models and people couldn't agree on which one was best, so it was always arguing, is it the Marsh model or the Schneider model? So some witty people would refer to it as totally confused infusion rather than target-controlled infusion. But I think that's actually been addressed now because we have the Eleveld model, which was being published from the Netherlands. And this is the first general purpose model. I think this is a game changer for me for TIVA, because it's the first, as I say, general purpose model where you don't have to, think about whether you want to use it in an obese patient, an elderly patient, or in pediatrics. You just put the individual patient data into the pump, and the software chooses the most appropriate PK model to deliver the drug safely and accurately and efficiently. So it's got built-in allometric scaling, which means that you can use patients, you can use skinny patients, tall, thin, whatever. Okay, and there are a number of, now I think there's at least 10 studies showing that the model performance is at least as good as dedicated models, i.e., if you were to use the P diffuser in children compared to the Eleveld, it's just as good as a P diffuser, because it pretty much uses similar data. There are also propofol monitoring systems in the pipeline. There's technology for monitoring propofol real-time in expired air, and it correlates actually very well with blood concentrations, because that's another thing that's been a concern with TIVA. With inhalation anesthesia, the argument's always been that at least you can actually measure the concentrations in expired air, but weren't previously able to do that with propofol. So what of closed-loop control? This is something I mentioned a little bit earlier in the presentation. Now, for me, the problem with closed-loop control, I think it can work very well for relatively simple things like the measurement of blood pressure. If you have an arterial line in a patient, it will give you accurate beat-by-beat feedback on what the blood pressure is, and then that could control the delivery of a vasopressor drug or whatever. And the same with glycemia, can be rapidly controlled with insulin and so on. But for things like depth of anesthesia, it's only going to be as good or reliable as information coming into it. Now, you can improve that to some extent by using things like fuzzy logic, artificial intelligence, but I think that our current processed EEG monitors, and certainly nociception monitors, are simply not good enough to be reliable for closed-loop control. The other problem is that closed-loop control doesn't generally anticipate things. By that, I mean, if I'm giving anesthesia to a patient, I see a surgeon poised with a scalpel in his or her hand ready to make an incision, I can increase the blood concentration, for example, bring fentanyl to an anticipation of that. But in this sort of system, what will happen is the surgeon makes the incision, the feedback would go to the nociception, the nociception monitor then have to increase the concentration around the fentanyl, it has to go into the brain, blah, blah, blah. So, patient's blood pressure is going to shoot up, everything's going to go off. So it doesn't anticipate. And I think for me anyway, I don't think we're going to see closed loop control in the near future, certainly not until we get better monitors. What about new drugs? A lot of drug discovery in the past was serendipitous, just by luck. For example, things like penicillin. Some was accidental. For example, the drug clonidine was an interesting history because clonidine was originally developed as a nasal decongestant. Some of the drug was sent over to the clinical researchers from the lab, and the clinical researcher, his secretary, the story is anyway, the secretary had a cold, so he put a couple of drops of clonidine in her nose, see if it worked, which it did. It decongested her nose, but she fell asleep for about 24 hours and developed what they euphemistically referred to as a rather low blood pressure. So then they decided to try it as an antihypertensive and found that it made patients very sleepy. So then better antihypertensives came along and it eventually became a sedative analgesic. But nowadays, of course, most drug development is actually planned, and it's a very high risk thing. From about 5 to 10,000 compounds that are screened, about 250 will make it preclinical. That's over a period of 3 to 6 years. About 5 then will make it to clinical trials, phase 1, fewer in phase 2, phase 3. That can take another 5 years or so, and you'll then end up with one FDA-approved drug. So that's high risk and high expense. Return on investment is tough. It's difficult for a lot of these drugs to recoup their development costs. The average new drug said to, and this is data from nearly 20 years ago, would have to have peak sales of about $500 million to earn a return greater than the industry's cost of capital. Now, what about the new drugs we have in anesthesia? Are they too short-acting? There's been a lot of emphasis on developing short-acting drugs, partly because of enhanced recovery, etc. But the problem with too short-acting is it may increase the risk of awareness. And in fact, we don't really need drugs to be very, very, very ultra short-acting. We want to have a smooth awakening. It doesn't have to be very, very quick. Patients need to wake up calmly and smoothly. So it's really going to be a big advantage for ultra short-acting drugs. They have similar pharmacodynamic effects, so there's no real advantage there. It's just the PK differences. And they may be a lot more expensive, as you saw from the cost of development. Non-anesthetic effects actually should be considered also with future drug development. I mean, this is something to think about. For example, propofol, as we heard, the benefits are not just with anesthesia, but with other areas, organ protection, free radical scavenging. With new drugs, we'd want to, certainly with anesthetic drugs, to be pretty sure that they don't have adverse immune effects. They're not going to produce neurotoxicity. They won't have undesirable side effects like nausea and vomiting, effects on cognitive function, etc. And one of the areas which has been used to try to develop very short-acting drugs is esterases, esterase cleavage. And esterases are widespread through plasma, red blood cells, interstitial tissues. They're not affected by abnormal pseudocholinesterase activity or drugs like neostigmine. So this has led to, the development of drugs like remifentanil, for example. It's also now being used to modify existing drugs. So there are also drugs like ketamine, which have been developed, so-called non-psychomimetic ketamine analogs. This is ester analogs of ketamine. They seem to retain effective anesthesia and analgesia, but minimizing those psychomimetic side effects. And as you may know, drugs like ketamine are developing new indications, like the FDA have now approved ketamine for the treatment of so-called treatment-resistant depression. So these are expanding even beyond their anesthetic uses. So there has been some work done on development of rapidly metabolized and ultra-short-acting ketamine analogs. One of the disadvantages that people thought of ketamine was its kind of longest duration of effect. May or may not be an advantage depending on the type of surgery that you're doing, but this idea here is to have rapid offset ketamine. Then, of course, remidazolam, I think, is already available in the United States. We don't have it in my country. I have absolutely no experience of this drug, just what I've read about it. It's got a license for induction and maintenance of procedural sedation in adults of less than 30 minutes, and compared to midazolam appears to have a shorter median time to being fully alert. To be honest, I never use midazolam anyway. I use propofol, but its main competitor, I think, would be midazolam, because most physicians are not allowed to use propofol, certainly not where I work. I don't know if it's the same where you are, but it does have similar adverse effects, and you can still kill people with short-acting drugs. So let's see how that goes. What about other things? This is isovalene. Isovalene is very interesting. It's a rare non-proteogenic amino acid, which is only found in meteorites. It was discovered in a meteorite in Australia, and its structure very similar to GABA and glycine, which are inhibitory neurotransmitters in the mammalian central nervous system. It has analgesic effects in animals because it activates peripheral GABA B receptors, but doesn't cross the blood-brain barrier. So there was some initial excitement about this in terms of developing it as a kind of novel and safe peripheral analgesic, and using it as an adjuvant to propofol for general anesthesia and sedation. But I haven't seen, I checked the internet for the lecture, I couldn't find anything particularly recent on this. Personalized medicine, anesthesia, and genomics. Well, we are, as specialists, very familiar with genomics because we all know about succinate apnea. We all know that drugs like codeine and morphine and tramadol vary considerably from patient to patient because of genetic differences. Things like malignant hyperpyrexia, how patients respond to neuromuscular blockers, how they respond to beta blockers. In fact, the response to anesthetics and pain, for example, the melanocortin gene makes people resistant to conventional anesthetic drugs. So my background is somewhat Celtic, from born in Ireland and educated in Scotland. So, we were familiar with how difficult it is to anesthetize red-haired people, and that there is a good genetic reason for that. But genomics also extends into other areas like chronic pain. Why do some people develop chronic pain and not others? Cardiovascular medicine, like beta blockers, response to drugs like clopidogrel, warfarin is becoming a bit obsolete, but there are commercial genetic markers for warfarin sensitivity. There are also things now like rapid sequencing technology to identify antibiotic-resistant bacteria, trying to guide the most appropriate antibiotics for severe sepsis, and then other things like gene expression, genotype, tissue expression projects. Clinical research can be, and in the future probably will be, changed a lot with pharmacogenetics, because research currently sort of averages out results. You have people who are good responders and poor responders. So you may have a drug which is very effective in subjects, but actually potentially dangerous in others. And that may not be reflected in a trial presentation. And the drug may even not be given approval because of that. And yet it could be a drug which could be extremely useful for certain people. So this is an area where pharmacogenetics may be very important, and things like NNT and NNH would become obsolete with proper pharmacogenetic targeted drug therapy. Pain is very much influenced by genetics, the nervous system, patient's individual behavior, and the drug responses. Chronic pain especially, only a small minority of patients subjected to certain tissue or nerve injuries want to develop chronic pain. Why is that? Once we know that when it occurs and once it's developed, it's very difficult to manage. But we also know that the susceptibility varies a lot according to your genetic makeup. And better understanding of this may well help us to identify patients who are going to be at risk of this and be able to, having identified them, treat them early at the time of surgery and hopefully prevent problems like chronic pain from developing after certain types of operations. So there's a lot of genes thought to be relevant to pain or analgesia. So I think the very key points about this, I think there are societal benefits, better efficient distribution of healthcare resources to those who are more that are likely to benefit from it, reducing healthcare costs, avoiding unnecessary, costly or risky interventions, and understanding these pain genes leads to the so-called personalized healthcare. So in conclusion, I think advances in the medical treatment of disease are almost certainly going to lessen the need for surgery and anesthesia in the future. Robotics will supersede technical skills. Hopefully we'll have better techniques to monitor what anesthesia actually is. I mentioned some of these in the previous lecture. Patients are going to be older, but less frail, and I think we have a greater emphasis on perioperative medicine and personalized medicine and better integration between specialists involved in the whole perioperative care process. Thank you very much.